Hi. So the first neuroradiology quiz case, let's start. Clinical history includes a 74-year-old man that presented with progressive right lower limb weakness and bilateral lower limb hyperesthesis. In addition, he complained about progressive constipation and urinary retention and anorexia on the day of admission. An extensive clinical workup was done. A lumbar puncture that showed mildly elevated protein, no white blood cells. PCR was negative for herpes virus and varicella virus. Negative serology to autoimmune markers. Thyroid function levels were normal and B12 vitamin levels were also normal. Normal tumor markers were also noted. Oligoclonal bands in CSF and other antibody markers were sent. Total body CT was performed that did not show any focal findings. Treatment began with steroids and plasmapheresis, but unfortunately without any positive results. In fact, the patient continued to deteriorate with loss of tendon reflexes and worsening lower limb weakness. Subsequently, MRI was performed. We see sagittal and axial images. Several findings were noted. First of all, a long segment of hyperintensity along thoracic and lumbar spinal cord, along with swelling of the cord. On the axial view, we can see that the hyperintensity involves almost all of the cord with some sparing of the periphery, and also we can note some flow void dorsally to the spinal cord itself, which brings us to the first question. What is the most likely diagnosis, considering the clinical and imaging findings? Is it 1, spinal intramedullary neoplasm, 2, spinal AVM, 3, CSF flow artifact, or 4, spinal dural AV fistula?
What's the pen number? Because someone.
Good. And the answer is 4, spinal dural AV fistula. Subsequently, an angiography was performed and confirmed the diagnosis. It showed a radicular artery with the direct contact with the perimedullary veins, and the lesion was embolized. That brings us to our second question. What is the least probable cause of hyperintensity of a long segment of spinal cord on T2? Is it 1, transverse myelitis, 2, neuromyelitis optica, 3, multiple sclerosis lesions, and 4, spinal dural AV fistula? What is least probable? And the answer is multiple sclerosis lesions. Subsequently, the patient in the days after embolization became steadily better and better with recovery of the different functions. Later MRI was again performed, and we can see a resolution of the findings. No hyperintensity, no flow voids, and the spinal cord is within normal width. That brings us to question number 3. What is the most common presentation in spinal dural AV fistula? Is it 1, slowly progressive symptoms involving thoracolumbar spine in middle-aged women? 2, acute myelopathy involving cervical spine in middle-aged men? 3, slowly progressive symptoms involving thoracolumbar spine in middle-aged men? Or 4, slowly progressive involving cervical spine in middle-aged men? Good. And the answer is slowly progressive symptoms, thoracolumbar spine involvement, and middle-aged men, just like in our case. A little bit about this pathology. So, presentation is initially non-specific. It can include pain, weakness, gait disturbance, paresthesia, and sensory loss. The deficits progress with time, and usually there is a long delay in diagnosis of averaging about 10 to 15 months. When diagnosis is made, bowel and bladder incontinence, erectile dysfunction, and urinary retention are almost always seen. The pathophysiology includes a radiculomeningeal artery. We can see it here, that fistulizes with a radicular vein, subsequently arterializing this venous plexus and leading to decreased drainage, to congestion and edema. And if left untreated, it results in chronic hypoxia and eventually ischemia and necrosis. This is a view from surgery that was performed for this pathology. We can see the artery and the engorged veins right here. So diagnosis. So basically the main modalities of diagnosis are MRI and angiography, but we have other possibilities as for initial steps in diagnosis. CT myelography can be performed as is shown here, and simple myelography can be performed, but as I said, MRI and angiography are the mainstay of the diagnosis. Again, showing the characteristic long segment of hyperintensity in the spine. And angiography is a tool that both confirms the diagnosis and is used for treatment. In addition to the regular sequences of MRI, we can use MRA. This is an example of MIP imaging that is done with MRI that shows exactly the root, the exact position of the artery and the fistula itself, and we can use also myelographic sequences that can show the engorged veins, the perimedullary veins, to a better extent. Some differential diagnosis that can be in our shortlist for this pathology. For example, a severe spinal stenosis can cause similar image when we consider the engorged perimedullary veins, as shown here, although it is not associated associated with hyperintensity of the spinal cord, and it involves a short segment. Another differential diagnosis is an artifact, actually a CSF flow artifact that can be seen here. That is caused by a pulsation of the CSF.
He's finishing his
Yes,
one
just
more.
2 more minutes. Okay, another differential diagnosis is the AVM, which is differentiated by the appearance of the true nidus in the spinal cord, in opposition to the spinal dural AV fistula. And finally, there is a long list of differential diagnoses for the long segment hyperintensity. I'm just showing 2 of them. The upper part of the image is transverse myelitis that can present with a long segment of hyperintensity of the spinal cord. In this case, without swelling, and the lower pictures show an example of an astrocytoma that can be also that can present as a long segment of hyperintensity with swelling and enhancement.
Can you please go?
Yeah, thank
Can you go?
That's it. Thank you.
Thank you very much.